guys. My name is Audrey Bautista, and I'm going to talk to you a little bit today about neurostorming. I actually did this lecture just recently at our Neuro Critical Care Symposium. I keep calling it a conference, but technically it's a symposium. And neurostorming is just kind of one of those topics in medicine that we don't really know how to identify yet. And so part of this lecture is going to be how to identify it, just kind of awareness of what it looks like, what it is, how we treat it, and kind of where you will see it. So for those of you that don't know me, my name is Audrey. I'm the neuroscience and critical care educator, and I teach all things about the brain, strokes, and critical care things as well, including CRRT. My background, if you don't know me, is I worked in cardio originally and then ended up working in neuro and fell in love with it. So let's go ahead and move on to our first slide here. So today, this is just kind of a summary of what we're going to talk about. We're going to define exactly what neurostorming is. We're going to discuss the pathophysiology behind its process. And we're going to discuss and understand treatment options and all the diagnostics. And there aren't a lot. This is a newer kind of topic that I think has been masking as other illnesses for a long, long time. And so discussing advanced recognition skills is really what we're going to get into today. Awareness is key. And we need to be aware everywhere in the hospital, in the ER, in the PCU floors, med-surg floors, and in ICU, and I will get to that shortly. But first, I want to kind of reflect a little bit and spend a couple moments on how awesome neuro is, because I know it's not everyone's forte. So what I'm going to do is talk about Dr. Edward Jenner here for a moment. I was actually on the Mayo Clinic proceedings recently. And they come up with, I guess, the 10 most influential people in medicine. And Dr. Edward Jenner, he's an English physician who actually discovered and suggested the possibility of vaccinating humans for other diseases. This was circa like 1780s, 1790s, but he ended up actually discovering the cure for smallpox and creating that vaccine. And this was back in 1796 while he was working at Berkeley. And the reason that I'm bringing this up is because what we're doing in neurology these days is we are trailblazing. We are just out there with machetes and boots and trying to figure things out. And the things that we come up with on a daily basis are really amazing. But we are a bit behind as compared to maybe cardiology. And so we're still figuring out how to recognize and treat a lot of these neuro symptoms. Dr. Edward Jenner was actually noted for saying, while the vaccine discovery was progressive, the joy that I felt at the prospect before me of being the instrument destined to take away from the world one of its greatest calamities, smallpox, blended with the fond hope of enjoying independence and domestic peace and happiness, was often so excessive that in pursuing my favorite subject among the meadows, I have sometimes found myself in a kind of reverie. And I just found that to be a really profound kind of quote from him. And that I can relate to a lot. I find myself, not that I'm over here inventing smallpox vaccines, but the things that we do in neurology, the things that I find out at the neuro conferences and symposiums, the things that our neurosurgeons are doing upstairs, they're innovative, they're amazing, and some of the best in the country. Fun fact about Dr. Edward Jenner is he actually died from a stroke. He died from 2 strokes. So he had one on January 26th at 73. He ended up dying. He had the first stroke and then ended up dying of that second stroke. It's always that second one that gets you, right? So let's go ahead and move on that note. This is a little bit more about me, just kind of trying to show you guys a little bit of who I am. On the right side of the screen, we've got Audrey at probably age 19 or 20. So this would be I'm not telling you how many years ago, but a long time ago. And that's kind of when I fell in love with neuroanatomy, was in that class. And on the left here, we've got my family, my husband, his name is Gene, my son, Bruce, and myself recently actually at Disney. This is another picture of Bruce, and I thought it was kind of appropriate. It was taken a couple weekends ago when we learned how to play with the water hose outside. And Bruce is a bit of a neurostorm himself, right? I thought this was a good picture. He's tachycardic, right? Because those pediatric vital signs are insane. His blood pressure is probably a little bit higher, and he's diaphoretic, right? So that's kind of what a neurostorming patient might look like. Not exactly, because Bruce was just playing with the hose outside, but let's get into that a little bit more. So really understanding paroxysmal sympathetic hyperactivity disorder, which is what this condition is called, neurostorming. To understand this, it's really helpful to first know the role of the sympathetic nervous system, and I'm going to get into that in a little bit. Where could we see this, though? So where could we see a neurostorming patient? Critical care units, definitely, because we deal with a lot of head traumas, whether they are acute. We don't necessarily at Baptist get level 1 traumas, although Wolfson does have its own kind of trauma program for peds, but in the adult world, we usually send those level 1 traumas or even level 2s, either to UF Health or HCA. But we do get some smaller or more mild traumatic brain injuries at Baptist sometimes. We can also see neurostorming in PCU floors. So I mentioned this earlier. So for my progressive nurses out there, you are going to end up possibly seeing this or coming across it one day. And I really want you to be prepared for these signs and symptoms and maybe understand it a little bit better. So that light bulb could go on in your head and say, is this neurostorming? What's happening here? It can actually also happen on med-surg floors. And it's due to the fact that when we have a traumatic brain injury, the onset of this neurostorming activity within our brain and within our autonomic nervous system can onset as early as 24 hours, although that's not real common, but it can happen. But it can persist for a couple weeks or even months afterwards. And so sometimes when we're downgrading these patients to the PCU and med-surg floors, they can be sitting on your floor and go into a whole neurostorm, and we might actually end up needing to readmit them to the ICU in that situation. So let's talk about what that looks like. So I told you that I wanted to talk a little bit about the autonomic nervous system. And so understanding PSH or neurostorming it's really helpful to understand our autonomic nervous system first. And so our autonomic nervous system is going to regulate body functions like heart rate, blood pressure, respirations, digestion, temperature control. It also prepares the body for a fight or flight response, increasing alertness, increasing heart rate, increasing blood pressure, among other effects. In PSH or neurostorming, the body becomes really dysregulated. And so instead of reacting appropriately to the stress or the stimuli, the sympathetic nervous system actually becomes hyperactive, causing dramatic and inappropriate bodily responses that would align with that flight or fight response. So this neurological phenomenon called neurostorming can occur in up to 15 to 33% of our comatose individuals with severe traumatic brain injuries. Again, we don't get a whole lot of severe at Baptist, but that number is still pretty significant and would have a pretty significant percentage with the less severe or mild traumatic brain injuries. When we have a traumatic brain injury or when we have a neurostorming event, this patient will end up declining in about 5 to 10% of the post-acute care settings. And it's associated with worsening outcomes and sometimes even death, just because it's not discovered or we don't treat it appropriately. But it's due to an excessive sympathetic nervous system activity that can develop after severe acquired brain injury, with about 80% of those cases occurring after a TBI. So it's more common, of course, in our pediatric population. The smaller our head is, right, the less that we have, the less room that we have within our skull to move. As we age, our brain actually will atrophy a little bit and get a little bit smaller, but the skull stays the same. And so our older patients actually have a little bit of wiggle room to maybe deal with falling down the stairs after drinking a whole bottle of Pinot Grigio and having a subdural hematoma. With our younger population, that skull is tight. And so the more youthful the patient is, even pediatric, we're going to see worsening outcomes, and the onset will be faster, quicker. The tighter that skull is, the less time that we have to mess around with. But this can manifest, I said earlier, as early as 24 hours post-injury. I see most of the statistics that are associated with the 24 hours are with the more severe traumatic brain injuries, but this can also occur in anoxic brain injuries, which we get a lot of at Baptist. So what is an anoxic brain injury? Anoxic, no oxygen, lack of oxygen. I've had a lack of oxygen to my brain. Maybe I was intubated improperly in surgery. Not really common, but it can and has happened. That would cause an anoxic brain injury. In Jacksonville, we actually used to have sort of a kind of sex trafficking ring up and down Phillips Highway. And for a long time, the female population, the youthful 18, 19, 20-year-old female population would show up, Jane Doe, down for unknown amount of time, found by boyfriend who was actually a pimp or someone who is injecting that person with drugs and using them, and then they end up over injecting them, stops their ability to move their diaphragm, so they stop breathing. And so they come in, and these patients aren't necessarily dead because heart is still pumping, brain is functioning somewhat, but when we do a CT scan, it does not look good up there. It's usually quite dark. And so that tells us that there's a lack of function with that brain. We will try to treat it and get rid of some of that swelling that occurs. But oftentimes these patients, just due to the amount of time that they were down, they will most likely be brain dead. But I am still holding out hope for some of them. But anoxic brain injuries are a really, really, really big association with neurostorming. This has a lack of attention in medical literature. And so a lot of the studies that I'm quoting right now, there are not a lot of them. And it's just due to the fact, I think mostly we were probably studying it prior to COVID, and then COVID hit. And all of the studies that we were doing were prioritized for COVID at the time. So I think we're resuming some of those, but we do have a lack of literature. So I'm hoping to revisit this subject again in the future, maybe with more information. So what is neurostorming? I have a fun little clip that I'm about to share with you that is from, I think it's called Blades of Glory with Will Ferrell. And this is kind of how I feel about the medical community's knowledge base of neurostorming in general.
I don't even know what that means.
No one knows what it means, but it's provocative.
No, it's not. It's
Gets
gross.
the people going.
Okay, so this is often a disease process that is coupled with that traumatic brain injury or another brain injury, sometimes even strokes, often goes unrecognized or misdiagnosed. The real name for it, guys, mentioned earlier, but here it is. Paroxysmal sympathetic hyperactivity. That is the name that nomenclature has decided on in the medical universe. And so what is PSH exactly? So PSH is a neurological condition that is characterized by sudden episodic bursts of excessive sympathetic nervous system activity. It is most commonly seen in patients who have suffered brain injuries, including trauma, hypoxia, stroke, or encephalitis. The condition was previously known by several other terms, which I will get into shortly, but it is basically an exaggerated stress response that can lead to poor outcomes and morbidity. These lead to intense periods of very uncoordinated sympathetic and parasympathetic responses, but the sympathetic responses really kind of take most of the attention in the body. PSH is a pattern of reoccurring bursts of dysregulated sympathetic activity resulting from some of the brain injuries that I've already mentioned. But these episodes are short, dramatic, and they're often triggered by some sort of stimulation. So I love this slide because it has had a lot of names in the past, arose by any other name. We have, I think, come up with 33 total misdiagnoses or misnomers for paroxysmal sympathetic hyperactivity disorder. We've called it dysautonomia, which is somewhat correct. So all of these are somewhat correct. It's just not the most correct, which is, what we do in the medical world. Sympathetic storming, of course, we're using our sympathetic system. The diencephalic seizures, we were originally, when we started seeing this, kind of thinking that it originated from the diencephalon. We have since discovered that we were very close in that ballpark, and the diencephalon does play a factor, but it's mostly going to be from our midbrain. It has also been called autonomic dysreflexia, autonomic hyperreflexia, autonomic dysfunction syndrome, paroxysmal autonomic instability with dystonia. That one was called PAID, P-A-I-D for short. And hypothalamic, which is not super accurate, dysregulation. And I'm sorry, there's a little bit of a misspelling there, but our hypothalamus is going to play a factor, especially if there's a stroke or bleeding or swelling around the hypothalamus. It will, anytime you interrupt or injure your brain somewhere near that area of the hypothalamus, you will have temperature and body temperature dysregulation. And that's oftentimes why we see that so much with our ICU population. We call it neurogenic temperatures because it's arising generally from the neuro, from our brain, meaning that we need to still rule out infections and things, but generally speaking, everything comes back negative, and we just kind of treat it with Tylenol and some sort of cooling or heating pad to get them regulated at 98.6 degrees. So who gets hit by this? Patients suffering from TBI, we've kind of covered that excessively, but also spinal cord injuries. We do a lot of spinal cord surgeries here. So for my Weaver folks that see a lot of spinal injuries, this is something that you might want to pay attention to. Diffuse axonal injuries, or DAIs. It's also associated with greater focal parenchymal lesions on CT imaging. So when you see the word parenchyma, it's usually referring to the squigglies, the gray matter of the brain. Also encephalitis, we mentioned that previously. We have a whole area of our in the sports world, mostly NFL, that suffer from chronic encephalitis. And so we can actually see some of these patients suffer from neurostorming. Tumors, specifically gliomas, subarachnoid hemorrhages, anytime you put blood in the brain. Blood likes to be in the vessel. It doesn't like to be anywhere else in the brain. If it is anywhere else in the brain, it might clot something off or clot something's ability to work. It will also possibly potentially block or obstruct our ability to move our CSF around, increasing our ICP. And generally this is stemming from the midbrain or the central injuries that would involve that brain stem. So pop quiz time. What part of your brain controls basic functions such as breathing, swallowing, and consciousness? I kind of just gave you the answer a little bit. but it is the brain stem. The synapses are going to be what's talking to one another. And the cerebral cortex, honestly, is just the part of the brain that doesn't include the brain stem. But it is actually going to be your brain stem that is causing this, or central or injuries in that area or involving that area. And so I love this picture on the left of the two boats with the water spout in the middle, because it kind of represents our two hemispheres of our brain with an injury right in the middle. And that's kind of what we're looking for, although it would be a bit deeper. But when we have our brain, when we're talking about our brain stem, we have three different portions of our brain stem. We have our midbrain, our pons, and our medulla oblongata. Our midbrain is going to be responsible for many vital functions such as breathing, consciousness, blood pressure, heart rate, even sleep, and sleep regulation. A lot of the sleep issues or shift wake disorders that we have arise from that brainstem area. 10 of our 12 cranial nerves actually run along the brainstem and arise from the cranial nuclei from the brainstem. The brainstem serves as the connection between the pons and the diencephalon. So like I was saying earlier, they were very, very close. We knew where it was coming from. We weren't exactly sure exactly where, but kind of in that area. As far as clinical presentation, this condition can present dramatically with paroxysmal tachycardia, arterial hypertension, tachypnea, hyperthermia. When patients are generally, when they have blood in their brain and their hypothalamus is injured because of it, we will see hyperthermia, but we can also see the other side of that, which would be hypothermia, because that hypothalamus is going to be dysregulated in its ability to control its own and maintain its own temperature. But it is often mistaken, neurostorming or PSH is often mistaken for a cardiac event because it presents as tachycardia. So you would be surprised, but some of your later signs when it comes to neurological conditions, or neuro worsening is what we call it in the ICU, neuro worsening, our neuro condition is worsening. The later signs of that are actually kind of more in the middle signs of that are going to be cardiac related. The earlier signs that we're looking for, and you can kind of take this as a blanket statement for just about any neuro condition, but if you are looking to assess your patient and you see any change in level of consciousness whatsoever, and I'm talking like I came into the room last hour and they gave me a Christmas ornament. Now I'm coming in this hour and they're screaming at me and throwing things and maybe even hallucinating. Sometimes we perceive that as delirium. But if it's coupled with some of these other vital signs, then that would be your indication that something could be happening. You can throw out the word neurostorming to the doc and just kind of plant the seed in his head. But it's going to present sometimes as a cardiac event, but make sure you're doing like a thorough neuro assessment on this person, because you will generally notice that their level of consciousness is greatly decreased. That's usually going to be your first sign. Then we have that persistent tachycardia. If we do not treat this, what it leads to is cardiac hypertrophy. And so this could end up leading to like cardiomegaly or other cardiac problems that the patient didn't originally come in for. This will also cause dehydration. These patients are usually at a free water deficit due to like a profuse amount of diaphoresis. So they will be sweating a lot. And it's usually due to that high blood pressure and high heart rate. They usually try to regulate each other, but they're both high in this instance. So this is another favorite movie of mine. What is this one called? Home Alone. This is one where they went to France. And I love this part with Katharine Hepburn because first of all, her scream is just iconic. And then secondly, it kind of reminds me of what's happening in neurostorming. So if you look at the bag, that's kind of maybe the synopsis all of these people that are passing the bag are going to be the little individual, you know, synapses moving the brain activity along. And then when you see the screen, when you see Katharine Hepburn kind of freak out, that's sort of our neurostorm. So I'm going to go ahead and play it.
Kevin's not here. Kevin's not here. Kevin's not here.
What?
And so basically it will kind of cause a lot of brain activity. There can be some dystonic movements that are associated with, they can also lose consciousness from this. And it just sort of makes it seizes your brain into a state of just impulse dysregulation. And that's kind of what happened in that scene right there. So the pathophysiology behind this, neurostorming is thought to be caused by an imbalance of the ANS, thought to be caused by any sort of TBI or some of those other disease process that we talked about. We talked about what the ANS controls. These symptoms, because the ANS is overactive, will lead to neurostorming, but it results in an uncontrolled disassociation between your parasympathetic and your sympathetic nervous systems. They're not exactly communicating well with one another or regulating themselves in any way. This will increase the morbidity of the patient and also their hospitalization stay. Prolonged states of hyperthermia can lead to like a catabolic state, and this leads to a huge increase in their serum catecholamine levels. So these patients will start releasing catecholamines because of this disease process, and so it sort of floods their whole body, and kind of the body enters into a hyperdynamic state, but due to that excessive catecholamine release. I love kind of the flood picture. It shows the water coming in. We live in Florida. I thought it was appropriate. But catecholamines will be flooded in our patient's body. And so these are some of the kind of causes of neurostorming trauma, like we talked about: hypoxia, stroke, either ischemic or hemorrhagic. A lot of people tend to forget that strokes, you know, there's two different types. There's a bleeding one and the non-bleeding one, the lack of blood one. And both of them really can cause the patient to neurostorm, but specifically with subarachnoids, there's a higher precedence of it. Infectious diseases, any sort of like meningitis or infection up here will lock the brain into sort of that same state, and it would activate that catecholamine release, possibly locking the midbrain into that state of dysregulation. Hydrocephalus is a less common cause, but it can cause neurostorming. A lot of times this is due to an excessive like dumping or not enough production of that CSF. We talked about gliomas specifically with tumors. And then also hypoglycemia. So basically how our autonomic system works is you have sort of the increased sympathetic activity. It goes up the spinal cord into the brain and then back down through the brain. So it's going to interrupt that feedback loop, creating no negative feedback to slow things down. So I like to kind of relate this to the resting portion of the cardiac cycle as well. If we're not allowing that to occur, our heart chambers are not filling adequately. So not quite the same thing, but still, since we have no negative feedback to sort of rest and slow things down, this causes that hyperadrenergic outflow and can result in multi-organ system dysfunction. This will involve the pupils, anything that involves 10 of those 12 cranial nerves. The salivary glands, they'll be very, very dry because we're putting out a lot of excess fluid elsewhere. We talked about the heart control. It will increase our heart rate and our blood pressure. It'll also kind of constrict our lungs, less perfusion to our liver, our stomach, our intestines. Our adrenal glands are going to be releasing a lot of those catecholamines, cortisol, and things like that. But it will slow things down in your GI system. Oftentimes if your patient has a feeding tube, like a dog off or a pig tube, you can go in and actually aspirate and notice that you will have a lot of residual, and it's because things are slowed down in their digestion. They're not able to rest and digest because their body is in this hyperdynamic state, and it's focused on other things right now. It's not so focused on how well we're digesting in our stomach. And so these patients may not be digesting well. We might actually have to lower or even pause their tube feeds or their feeding for a while. So this is a fun picture that I found from the Organization of the Autonomic Nervous System, which I didn't know there was one, but I thought it was really awesome that they came up with one. And I thought it was a really nice picture that sort of explains the different branches of the sympathetic nervous system and the parasympathetic nervous system. So normal transmission of feedback goes from the cortical surface of the brain and is relayed through the brainstem, the pons, and the spinal cord, and comes back up. With PSH, you actually lose your inhibitory neurotransmission control, and the neurotransmitters that normally slow things down, you lose their ability to play at it, like as a part of this game. This results in an uncontrolled state of stress. Like I said earlier, we don't have that sort of kind of diastole to calm things down. But it will affect our whole body, increasing acetylcholine, contracting a lot of our muscles. Let's move on so we also have something called a resting membrane potential. The resting state of a neuron is also known as their resting membrane potential. And this is the electrical state in which the neuron is not actively transmitting signals. The state is characterized by a negative change inside the neuron compared to the outside. And this is typically around, I think, like they have a little picture up there, negative 70 millivolts. But basically, this resting membrane potential is what allows some of that extracellular and intracellular fluid to transport across those membranes, giving the patient what they actually need intravascularly. So clinical presentation, what you're going to be looking for is rapid, repetitive fluctuations in vital signs. This is going to be characterized by restlessness and agitation. I told you one of the first changes that we're going to see is a decrease in LOC. I have a feeling, I'm just going to admit it out loud, if I'm ever, injured in my midbrain or have a subarachnoid or an anoxic brain injury, and I am exhibiting a neurostorming level of consciousness change, I will probably present with a lot of restlessness and agitation, just based off of my personality. But a lot of our patients do as well. And so recognizing that and going, you just gave me a Christmas ornament last hour. We were joking last hour, and now you want to throw things, or now you're kind of like jerking maybe, but really agitated towards me. This would be a change in level of consciousness. Also, if we see those cardiac presentation symptoms, tachycardia, tachypnea, hypertension, diaphoresis, go ahead and make sure you get a blood sugar, right? Anytime there's anything neuro going on, we always want to rule out hypoglycemia, just make sure that's not adding into things. There's also hyperglycemia, which could throw you into several different disease processes as well, but the pupils will dilate. So this would be a patient that I want you to check their pupils because they're not going to be constricted. They may even have that dystonic abnormal motor response that I was talking about. And of course, I mentioned earlier the increased tube feed residuals. When you're seeing increased tube feed residuals in a patient, it's because we're not digesting. So if you're seeing a lot of it continuously, then maybe we need to slow that tube feed rate down. But that abnormal motor response, or the dystonia, we're going to talk about in a little bit. But first, I have another pop quiz for you. The brain plays a crucial role in controlling the heart. I hope that over the last several moments, you guys have come to the realization that the brain literally controls your entire body. And so it's a very, very important organ, and it absolutely plays a crucial role in controlling your heart. So the brain, specifically the medulla oblongata, one of my favorite medical terms, sends the signals to the heart through the autonomic nervous system. This system regulates all those involuntary bodily functions that we talked about. The sympathetic branch of the ANS increases heart rate, blood pressure, and in response to stress or exertion. The parasympathetic branch slows down the heart rate and lowers the blood pressure when the body is at rest. So because we're not having that parasympathetic moment, it's sort of our diastole, for lack of a better term. Therefore, the brain constantly monitors the body's needs and sends instructions to the heart to adjust its rate and rhythm accordingly. This ensures that the heart pumps blood efficiently to meet the body's demand. We need to make sure that ejection fraction is good at all times, right? And so kind of the same thing with the heart, but we're working with our autonomic nervous system. So since the medulla oblongata is one of my favorite medical terms, I had to include this.
The medulla oblongata.
Mama
The
said,
medulla oblongata.
So that's how I feel walking around the hospital most of the time, when I'm trying to explain to people, what is actually happening with their patient. They're like, no, it's a cardiac event. I'm like, no, it's the medulla oblongata. And I do love that term, but the medulla oblongata is going to be a really important portion of that midbrain function. And in this movie, they actually relate the medulla oblongata to an alligator and its crotchety ability to just kind of go find food. It's sort of that caveman area that it just knows what it needs and goes and gets it. And so I love this movie. I thought it was a fun way of bringing in the medulla oblongata and helping you guys maybe understand that. But I really want to talk about dystonia first. So what is dystonia? Dystonia is what we are oftentimes in the hospital setting confusing with seizures. So I mentioned earlier that we kind of were looking at this as maybe like a diencephalic seizure activity, and it's because of that dystonic jerking movement. This can eventually lead to a seizure activity disorder if it's left untreated, but first you will see the dystonic posturing is what it's called. And so this is going to be spontaneous posturing, which could lead to the chronic immobility if it's left untreated or if it goes unnoticed. The characteristics are going to be sustained muscle contractions, abnormal postures. It can affect any part of the body, including the face, neck, limbs, and trunk. But it was originally kind of thought to be seizures caused by the diencephalon. So you might see like muscle twitching in the face, as they're having these other symptoms. And you may even see a lot of like involuntary neck muscle twitching, and it has to do with that sort of slide that I showed you guys earlier with the transport of electrolytes. The resting membrane potential doesn't allow that to cross the membrane, and so this patient is actually suffering from dystonia due to that. So what are some triggers that may trigger a patient to go into a neurostorm? We talked about how it can onset as early as 24 hours. It can last for weeks up to months. Under sedation in our neuro population, if we have a more midbrain kind of involvement injury and they're not sedated properly, although we don't like to over-sedate patients in neuro, but they just might need to be nice and properly sedated, because if we're stimulating them a lot and they have this disconnection between the parasympathetic and the sympathetic branches of their autonomic nervous system, they're not going to have this resting potential. So as soon as you stimulate them, they may go into a full-blown neurostorm. And that could be due to under sedation. Endotracheal suctioning. Anytime we suction a patient, I don't think anybody would like a tube stuck down their throat and being suctioned. So I imagine that would be pretty painful or annoying. Repositioning them in any way, shape, or form, even the head movement. We generally in neuro keep their head at about 30 or 45 degrees. Pain responses, if they are suffering from a lot of pain, sometimes being in the bed, this can trigger a neurostorming event. So if your patient has back pain and they also have a pretty severe or moderately severe brain injury that's involving that area, I would be maybe making sure that that back pain is taken care of, as long as the patient can communicate, of course. Noise, family, those two kind of tie together. We try to keep it very quiet or as quiet as we can, and cluster our care when we're in the neuro setting. So nurses, make sure that you're rounding with the doctors. Doctors, make sure you're rounding with the nurses or asking before you go into the room, because we really need to be clustering our care. And this goes for PT, OT, or anybody else that's watching this. The less we stimulate them, or the more that we kind of cluster it and make sure that we're stimulating them in blocks and giving them that time to rest, you might be able to avoid some of this. But the family can actually cause emotional responses in the patient that can be kind of significant. And so imagine, seeing mom or dad or husband or children and feeling that stress and looking at their face, that can cause them to go into a full-blown neurostorm. Also, urinary retention. So making sure that we're scanning those bladders. If we see a lot of agitation with any neuro patient, another thing that they get is neurogenic urinary retention. And so if we've injured the area of the brain that maybe controls our ability to tell our bladder, hey, it's okay to release that urine we're retaining, that's going to create a lot of pressure in their abdomen and may actually drive their blood pressure up and put pressure on other organs. It's also very uncomfortable. So I just want to point out that I've been a part of quite a few scenarios where we have been given the patient Seroquel, maybe even sedating them and kind of labeling them as going crazy, whereas they were previously not. And it's because we DC'd the Foley a couple days ago. And so we know that the patient is voiding, we just don't know how much. And so the patient will start to get increasingly agitated, trying to get out of bed, and we're throwing drugs at them when we could just kind of scan that bladder and see if they're retaining anything first. So with neuro patients, neurogenic temperatures and bladder retention are pretty big takeaways from this lecture. So diagnostics are going to be things like EEG. So EEG is electroencephalogram. It's essentially just like an EKG just on your brain, on your head. We will actually place little electrodes all along your brain, all along your head, and try to identify within a specialized neuro physician that specializes in the electrical system of your brain. And so they will actually take a look at these waveforms analysis. And there's a lot that goes into these waveforms, just like EKGs. This will usually show our delta waves. Delta waves are thought to be branched off of our parasympathetic system. Some theta waves, but there will be no epileptiform discharges, meaning that this is not coming from epilepsy. This is not a seizure type of movement. So we might be seeing what looks like a seizure movement. We put EEG on to rule it out. And the doc tells us that they don't see any epileptiform discharges on the EEG. So then we would take it off and we've ruled out that this is not a seizure. Also, their ICP. So I like to talk about ICP to anyone and everyone around the hospital because it's actually something that you can calculate very easily by just looking at your blood pressure and knowing kind of a normal ICP. So an ICP normal value is going to be anything less than 20. So $20. Anything less than 20 is good. Anything higher than that, we might be looking at possibly the brain exiting the skull, which is herniation. So rapid rises in ICP can cause a lot of trauma to the brain. It's not good for their brain. It can cause the neuro worsening and even death. But a CPP is what we are going to calculate. And so a CPP is called a cerebral perfusion pressure. And it's a very simple calculation. It is just MAP minus your ICP. So if you just walk around the hospital assuming that every patient's ICP is 20 or less, I would just throw 20 in there, assume that it's as high as it can be. And you subtract that from their MAP, that CPP normal range should be in 60 to 80. So let's say I take your blood pressure and your blood pressure, your MAP is 65. And I'm assuming that your ICP is 20. That is not between 60 and 80. So this is a really great explanation of why we like to keep their blood pressures a little bit higher in the neuro world. So if we are not keeping that CPP before it's between its normal value of 60 and 80, we could actually be hypoperfusing the brain and making things worse. So it's just kind of a fun little takeaway that I thought you guys would enjoy learning about today, but you can calculate this on any patient if you just remember 20 bucks, normal ICP is 20 or less. Subtract that from your MAP, it should be between 60 and 80. And I like to remember the 60 and 80 because that's generally the range in which the physicians like us to keep the MAP full anyway, anywhere between 60 and 80, usually on the higher side, but it kind of helps you to remember those things. So we talked about catecholamine earlier and the catecholamine flood that's going to be entering the patient's body. You can do serum catecholamine levels on this patient, but they can be costly and they do not change the treatment in any way, shape, or form. So alternatively, what a lot of physicians have been doing at other hospitals is they will get a urine sample, and the urine sample is cheaper to analyze, but it will absolutely show some pretty high levels of epinephrine and norepinephrine in their urine because there's, again, a lot of catecholamine activity, and they're just the body's just trying to get rid of it in any way that it can. And that's assuming if they're urinating. But this, the serum catecholamine levels can be pulled, or the urine levels can be pulled either during the resting state of the episode, or during the episode itself. So differential diagnoses, I always like to include these because they always present as neuro worsening. Neuro is one of those areas of medicine that can be really tricky to identify what's going on with your patient because a lot of things mask each other. So neuro worsening looks like a lot of things. We want to rule out infection, right? We want to rule out seizures with the EEG. We want to rule out thyroid storming, so maybe pull in some thyroid levels on them. Rule out neuroleptic malignant syndrome, and then, of course, withdrawal. And these will all kind of help point you or point your physician, your team in the right direction of getting the diagnosis of PSH and realizing that this is neurostorming. So now what I'm going to do is talk a little bit about pharmacotherapy. Most of the pharmacy options that we're going to be using with this patients are going to be things like opiate receptor agonists, of course, dopamine agonists, non-selective beta blockers, alpha blockers, your GABA agonists, and sometimes even combo therapy. So the combo therapy differs from hospital system to hospital system. I said at the beginning of the lecture that there's a lack of uniformity in the treatment, and that is due to a lack of research. So we kind of need to work on this topic a little bit more, but there have been two really well cited combo therapies that other hospitals are using. So one of them is gabapentin, an opiate, and bromocriptine. And then the other one was opiates, propranolol, and baclofen. And I'm going to kind of talk about that a little bit. So your opiate receptors are going to be things like morphine, fentanyl, oxycodone. These appear to modify the ANS changes and their posturing. And so we're kind of decreasing that posturing activity with this. This decreases that hyperdynamic response. It will actually help with the cardiac contractility as well. And it decreases posturing episodes, but it is dose dependent. Our GABA agonists. So our GABA agonists are going to be things like baclofen and gabapentin. And they are usually used for spasticity and pain modulation. So baclofen is going to be, kind of a muscle relaxer. It acts on the inhibitory interneurons in the spinal cord. And that's why we see it a lot on our spinal patients. The great muscle relaxer for our spinal patients. And it doesn't have a huge CNS effect like some of the other muscle relaxers do. It has been used intrathecally, which if you don't know what that word means, that means that we can actually introduce it into the brain and or spine, the fluid kind of circulating around in the CSF, we can actually insert it into those areas. And it has actually been significantly improved symptoms after using intrathecal baclofen. So I thought that was really interesting. Gabapentin as well, it acts on the alpha-2 calcium channels in the dorsal horn of your spinal cord. And so this is shown to reduce the severity of the concomitant medication requirements. I think I'd probably err a little bit more on the side of baclofen in this situation, but I would love to see what Dr. Naval thinks about that. Our dopaminergic agents are going to be bromocriptine, amantadine, and levodopa. Bromocriptine has been associated with decreased in temperature and sweating. So dopaminergic agents are also going to provide a little bit of dopamine to that patient, which can be associated with kind of like some pain control. Our beta blockers are a huge category. I kind of want to spend some time on that. We specifically like to utilize our B1 cardiac selective drugs. I'm sorry, let me repeat that. Our B1 cardiac selective drugs are not as effective. So this is going to be like metoprolol. Propranolol is actually the most effective, and it's because it actually crosses the blood-brain barrier, reduces the severity of the episode, it decreases circulating catecholamine activity, and reduces your cardiac workload and your catabolic drive. So propranolol is a really huge drug. I see it used a lot in trauma programs. So UF Health, I know, uses propranolol on almost all of their severe TBIs. And I would go ahead and probably assume they're using it on encephalitis patients and subarachnoids as well. Our alpha agonists are going to be things like clonidine. This acts centrally as well as peripherally by reducing circulating catecholamines and heart rate. So you can kind of use a combo therapy to reduce that catecholamine activity and flood. So clonidine is going to block adrenergic influences of the hypothalamus and the ventrolateral medulla. So beta blockers, again, propranolol and labetalol are going to be the most effective to help control that heart rate and blood pressure. Our alpha-2 agonists are going to be things like clonidine. Also, our decadron is going to fall into the alpha-2 agonist or to reduce sympathetic outflow. Gabapentin and baclofen are for spasticity and pain modulation. Opioids, of course, also for pain management. Benzos, lorazepam, sometimes I haven't seen them cited as much in some of the recent articles, but they have been used in the past to kind of help with that muscle relaxation, specifically Valium, and anxiety control, of course. So in summary, we kind of want to decrease any stimulus from this patient. We kind of want to cluster our care. We want to recognize earlier signs of neuro worsening, which is always going to be a change in level of consciousness. And that change in level of consciousness might actually be due to the fact that the patient is more agitated. It doesn't have to be like a GCS of 15 to a GCS of 10 or 9 or 11. It could just be that they're more increasingly agitated. And so some of these big takeaways: paroxysmal sympathetic hyperactivity is a complex condition of exaggerated autonomic responses following severe brain injury, subarachnoid infections, encephalitis, and even some of our more mild traumatic brain injuries. This is often involving sudden, intense periods and episodes of heart rate, blood pressure, temperature, and motor posturing, loss of control. While it's not fully understood, the damage to the brain's inhibitory control centers is believed to play a huge key role. PSH is diagnosed clinically, managed with meds and environmental strategies mostly these days. We may end up paralyzing the patient sometimes. Just sort of depends on what the physicians like to do. If we are paralyzing the patient at all, we specifically use rocuronium as opposed to succinylcholine. And it's because succinylcholine in our neuro population, and this might be really helpful for my ER nurses, increases ICP. So I kind of like to tell my neuro nurses that kind of sucks, because it does for a neuro population. We would much rather use a rocuronium to paralyze them. And that's if we are still seeing some of the dystonic posturing. I think a lot of physicians would probably steer into that area, maybe paralyzing them. But with timely recognition and management, the burden of PSH can be reduced. We could improve outcomes and the quality of life for our patients and families. With this dystonic posturing, if we allow it to continue, the patients can leave with dystonia and end up having to work with PT and OT for long, long periods of time, costing more money and ultimately worsening their outcome. So I'm going to pause for a moment to see if we have any questions. But I don't think there are a whole lot on this subject because it is a highly understudied one. So I hope this was helpful for you guys at the bedside out there. I wish you all the happy GCSs, and I hope this doesn't happen on your floor. But at least now you'll have some of those tools to recognize the earlier symptoms of it and call the physician and let them rule that out. But I really appreciate your time, guys. These are my citations if you'd like to see all 5 of them. Thank you.